Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about breast cancer with Drs. Parisa Lotfi and Mehra Golshan. Dr. Lotfi is an assistant professor of radiology and biomedical imaging, and Dr. Golshan is a professor of surgical oncology at the Yale School of Medicine, where Dr. Chagpar is also a professor of surgical oncology.
So, Parisa, maybe we can start with you. Can you tell us a little bit more about yourself and what it is you do?
Sure. I am a radiologist with expertise in breast imaging. And breast imaging includes all modalities, for example, mammography, ultrasound, and MRI. Not only do I look at images, but also I perform all the different procedures related to these modalities. Part of my job is screening for breast cancer, and part of it is diagnostic imaging, which is related to findings we find on a screening mammogram, screening ultrasound, or screening MRI, and also addressing women's specific problems related to the breast, either issues that they find themselves to be troublesome or directed by their physicians, either a gynecologist, breast surgeon, or a primary care physician.
Fantastic. Mehra, how about you tell us a little bit more about yourself and what you do?
So I'm going to start off with a disclosure that I happen to be married to Dr. Lotfi, and just for any disclosures up front. So I'm a breast cancer surgeon. So when Dr. Lotfi identifies a patient that has an abnormality, and if she undergoes a biopsy, or occasionally he, and they end up having a malignancy, a breast cancer, atypical cells, they come to see me or one of my counterparts to discuss next steps, and it's usually operative management. The great thing is with widespread screening in the United States, we're able to detect breast cancer often at a very early stage, which often gives them many treatment options, including surgery, sometimes drug therapy, sometimes radiation therapy. So often after a diagnosis, surgery is the next step. And then we talk about the path that patient has to take during their journey.
And so, it is Breast Cancer Awareness Month. And so often during Breast Cancer Awareness Month, we talk about screening for breast cancer as a mode to find cancers early. And as you say, Mehra, detecting it early often leads to better therapeutic outcomes simply because we can treat it earlier. But Parisa, back to you. I think one of the things that our audience might be confused about are all of the recommendations for screening. It seems that, every few years, the guidelines with regards to screening change. Can you tell us a little bit more about where things stand now? Who should get screened? How often? With what? When should they start? When should they stop? All of that good stuff.
Yes, of course. How much time do we have now? This is quite an interesting and controversial topic. And I completely agree with you. Even as physicians, we are confused about the recommendations. I'm going to kind of categorize this into what patients need to know, what physicians need to know, and what radiologists are recommending. As far as patients, I completely agree. There is all kinds of mixed messaging that is out there. There is the media influence. There is the task forces recommendations that change quite a bit. And then there is all these different societies that have similar but slightly different recommendations in terms of screening. So what patients need to know is what is their potential risk. And this is what the ACR and the other American College of Radiologists and Society of Breast Imaging and other societies basically categorized as self-awareness. Patients need to know what kind of risk they may have. And this is a conversation between their doctor, their family history needs to be included, their personal history needs to be included. And also race and ethnicity is a huge factor here, as studies have shown. And now we know very clearly that African Americans and Hispanics have a different risk factor compared to whites and other races. And they are more likely to die from breast cancer. And if they get breast cancer, it's more likely to be an aggressive kind and at an earlier age. So this is not, screening doesn't apply to everyone equally, including the age they start. So the conversation about what is my risk, how should I care about my breast, starts in the 20s. Currently, it's recommended patients start this conversation at 25 so that primary care physicians and gynecologists know where this patient falls in terms of breast care, what their specific needs are. But on the average, the recommendation for an average risk woman is to start screening mammography at 40. And the task force that just recently changed their recommendations in May and currently has a draft out there, changed the recommendation from 50 to 40 every 2 years, which is very reasonable. American College of Radiology and American Cancer Society recommendations are starting at 40 every year for an average risk woman. And basically, we say continue to be screened until a woman's lifespan is diminished because of comorbidities or that it's determined they have less than 10 years to live. And that generally is at about age 75. That is, again, a conversation to be had with a primary care physician to determine what every woman's desires and needs for screening are. I don't believe women in their 90s need to be screened because as we get older, breast cancer becomes less and less aggressive and remains to be very treatable. Women who are at higher risk of breast cancer, as determined by their physician or different risk models, completely different category. They need to be screened much earlier and with more modalities, for example, MRI in addition to mammography at an earlier age. And there is different categories of risk: patients who have a genetic mutation, patients who have had radiation to their chest wall need to be screened with mammography starting at age 30 and MRI as well annually. And anyone else who's determined to be at about 20% or higher lifetime risk of developing breast cancer needs to be, again, under surveillance with both MRI and mammography on an annual basis. So very complicated, very confusing for patients and clinicians. But definitely women need to remember to start the conversation early and not wait for age 40. They may need to be screened much earlier than that.
So, Mehra, I want to bring you into the conversation here as well. You know, one of the things that Parisa mentioned was really understanding your risk. And I think that in this day and age, you know, now that we have a lot more understanding about genetics and genomics, people are beginning to understand their risk better. Can you talk a little bit about who is a candidate for genetic screening, what that entails? Because certainly it seems to have a ramification in terms of screening and early detection.
Another question that may require a lot of time to answer, but trying to make it simple, is that it's actually not well determined who needs to have genetic testing. There are groups and organizations and some studies that suggest that anyone who ends up being diagnosed with breast cancer should undergo genetic testing regardless of us having a strong family history or not. And there are a lot of pros and cons associated with this. The simple thing is, if you do undergo genetic testing, it ends up being relatively simple. It's a tube of blood. It's sent out to one of several laboratories in the United States, and then a result comes back. Now, that result may have things that are what are called actionable mutations, so things like BRCA1 or BRCA2, the Angelina Jolie's or Christina Applegates of the world, where we know what that risk associated with them of developing breast cancer and potentially ovarian cancer and other malignancies in cancer. There are newer mutations that we're getting more and more information on, which can also be actionable as well, which would either mean more intensive screening, as Dr. Lotfi was speaking about, so alternating mammogram and MRI every 6 months. Some women will go down the prophylactic route of reducing their risk of developing breast cancer at the highest degree, which would be removal of both breasts with or without reconstruction. Yet sometimes results will come back with what are called things like variants of uncertain significance, and where we don't know, at least at this point, having a mutation like that would put them at a higher risk or not. There are groups that argue that we should be much more nuanced in terms of who should undergo genetic testing. So going through family history in much more detail. And if you start, if you meet a patient and they tell you that their mother had breast cancer at a very young age and their grandmother had ovarian cancer at a young age, well, then, you would think about getting that patient to genetic counseling. The good news is, in the United States and many parts of the world, genetic testing has become much more available. The cost of testing has gone down in the United States. A little over a decade ago, there was only one company in the U.S. that did the testing outside of laboratory settings. It actually went to the Supreme Court, where they ruled that genetic testing and information could not be held by one company, and now there are many out there. So that's one way of approaching women that are potentially at higher risk.
So just one follow-up question for you, Mehra, on the genetic testing piece is that, some patients might be concerned about the ramifications of getting this information in terms of life insurance, health insurance, employment discrimination, et cetera. Can you speak a little bit about that, especially in an era where our access to genetic testing is widened?
Another great question, and area where certainly patients and their families could become concerned about fear of not being able to be insured, or insurance or other policies that they have would be taken away. The good news is that in my 2 decades of doing this, I've actually never had a patient of mine or heard about a patient directly from my colleagues that had to have something like that happen to them. So it is I think a safe route to take in terms of if your physician, your care team thinks that you need genetic testing performed or done, that you can safely do that without ramifications in terms of losing eligibility for life insurance or coverage along those lines. Now, the discussion of who else should potentially be tested in the family and how that information is passed on, that is more nuanced and something we can certainly discuss.
Perfect. Well, there's a lot more to discuss, but first we need to take a short break for a medical minute. Please stay tuned to learn more about breast cancer with my guests, Dr. Parisa Lotfi and Mehra Golshan.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their Center for Breast Cancer provides coordinated state-of-the-art care for patients with benign and malignant diseases of the breast. Learn more at smilocancerhospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone, there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting, even after decades of use, can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as the Battle II trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guests, Dr. Parisa Lotfi and Mehra Golshan. We're talking about breast cancer in honor of Breast Cancer Awareness Month. And right before the break, we were talking about recommendations for screening and so on. Now, Parisa, I want to come back to you. Another topic that I think a lot of women have heard about but might not be really clear about is this whole issue of breast density. Can you kind of define what breast density is and what the implications are in terms of a patient's risk for developing breast cancer, as well as any other imaging that they might need in terms of their screening?
Yes, of course. This is such a great topic. Every woman needs to know how dense their breasts are. And every time a woman has a mammogram, they are notified of that fact. And this started about a decade ago, and Connecticut was one of the pioneers in initiating this. And as of 2024, I believe, mid-year, it's a federal mandate that every woman be notified of how dense they are. The density is a descriptive term, and it implies how white a mammogram is when I look at it. The reason it matters is because cancer is also white. And it's basically like, where is Waldo? How can we find this cancer if white on a background of white is what we see? If a woman has dense breast mammographically, their mammogram is not as sensitive as another woman who doesn't have dense breast to detect cancer because of various factors. For example, the tissue blends in and we just can't see it. And that's why it's important for women to know if they have dense breasts, because they should know that their mammogram is not as great as it should be, and therefore they're a candidate for supplemental screening tests. If they're an average risk, they can get an additional ultrasound for screening, and if they're at an elevated risk, they can get an MRI for additional screening. Density by itself is a risk factor, but not a huge risk factor. We do consider it, but it doesn't really add much. So if you're in a state like Connecticut and insurances cover that screening ultrasound, why not? We should all go ahead and get that if you have a dense breast. And every time a woman gets a mammogram, they're sent a letter to their home, or they walk out with a letter that has a density statement in it. If you read that letter, it will tell you if you have a dense mammogram or you don't have a dense mammogram. And it usually tells women that if you do have a dense mammogram, you're a candidate for supplemental screening. And that supplemental screening is considered diagnostic workup and needs to be ordered by your physician.
So just one follow-up question, Parisa. When somebody gets a mammogram and it says that they have dense breasts, does that mean that they have dense breasts forever and ever, or does breast density change as you age?
For the most part, density doesn't change. It tends to become less as you age, but not that much. The density in the breast that we see is basically the fibroglandular tissue that's actually breast related. The rest of it is fat. And women who tend to be smaller in physique, they're in shape, they have less body fat everywhere, they tend to have dense breasts. And obesity leads to having larger breasts. I have seen women who are in their 70s, 80s, and 90s who still have dense breasts. They always had dense breasts. And the composition of the breast doesn't really change that much. With menopause, there is involution of the fibroglandular breast tissue, and the breasts tend to get more fatty, but I'm yet to see a woman who goes from dense to fatty over a few decades.
Mm-hmm. Mehra, as Parisa mentioned, density being a risk factor for developing breast cancer, but not a huge one. Can you talk a little bit more about some of the other risk factors that our audience should be aware of that might be modifiable, and some that might not be modifiable?
Yeah, no, it's a great question. So there are often things that are brought to me, by the patient once they're actually diagnosed with breast cancer. They'll say, "I'm going to change my diet. I'll stop drinking. I'll not eat meat anymore." I mean, those types of things may be good for overall health issues, but to actually change their ultimate outcome from surgery and drug therapy and the next steps, it's really, really minimal, if none at all. We do know that women, once they're diagnosed, if there is a large weight gain after cancer surgery and treatment, that has negative impact on outcome and survival. But things to do when you are in this kind of screening age and you do not have a cancer diagnosis, certainly knowing your family history, and if there is that high risk based on multiple generations having breast or ovarian or types of cancers that are linked together, is to consider genetic testing and genetic counseling. I ultimately think that large scale changes in one's diet or lifestyle may make some, but not a huge difference in breast cancer overall risk and outcomes. And I think there's so much that we've done with the screening, which has been part of our discussion today, with that earlier diagnosis and much better treatments that lead to better outcomes for women with breast cancer.
So, Parisa, when we think about the landscape of breast cancer and breast cancer imaging, there's been a lot that's changed over the last several decades, a lot of advancements. Can you talk a little bit about some of those newer techniques? I know that you had mentioned earlier about MRI, but now people might be hearing about things like molecular imaging or contrast-enhanced mammography. Can you tell us a little bit more about those and whether that's hype or whether that's ready for prime time, or how you feel about all of those newer imaging techniques?
I love the newer imaging techniques. They're fantastic tools in our toolbox. However, they're expensive and not widely available. Starting with MRI, which has been part of our toolbox for decades, it's a fantastic tool. It's the best tool we have so far for detection of breast cancer. However, it does require an injection. There is a dye that the patients receive. It goes into the vein. It gets taken up by the breast. It preferentially gets taken up by cancer. And so when we look at the images, we can tell that this abnormality looks like a cancer. It's taken up dye. And this other abnormality that has not, and therefore we can be very specific about what needs to be addressed and treated in that breast. It is really a very sensitive test tube, so we end up with unnecessary biopsies that don't lead into a cancer diagnosis, but still need to be evaluated. But it is a great tool, and the density of the breast is irrelevant when you're looking at MRIs. It's a very good functional test for us to know what we need to address. And if it wasn't expensive, if it was widely available, and if it didn't require an injection, it would be the only way to go for screening breast cancer. Just to make some clarifications in terms of MRI, MRIs are currently an adjunct to screening mammography because of all those reasons that I mentioned. There are places that have a slightly modified version of the screening MRI, where in some states and some regions, patients can pay out of pocket and have those kind of super fast MRIs for screening purposes. And they're, because you pay out of pocket, insurance authorization is not an issue. The other test that has recently, I would say in the last 10 years, has come to become kind of highlighted by our research is contrast-enhanced mammography, which I have some experience from my professional life with it. And it's an amazing test. It's very similar to MR in that it's a dynamic study. It requires an injection, but it combines functionality with a mammogram in terms of a patient will only need a mammogram and an injection. They can skip the MRI, and we can actually see dynamically what's happening with different abnormalities on a mammogram. Are they taking up the dye, or are they looking suspicious, both in terms of morphology and their functionality? Unfortunately, that is also not widely available. And if it was, it's not an expensive test. It's basically a mammogram with an additional charge of $15 or so for the dye that the patient receives. And in an ideal world, I really would see that replacing screening mammography. But right now, we are years away from that. There are centers in New York, and locally, Yale is working on it, doing some research. In Boston, there are institutions that are offering that, not for screening purposes, but right now mainly for diagnostic purposes. And I'm hoping that we do move towards that, because I think it's a great test.
What about some of the functional imaging? People talk about things like positron emission mammography, which sounds like a combination of a PET and a mammogram.
It's actually great that we have so many different tests to offer patients. The PEM, or positron emission mammography, is one of those that is not widely available. There are only a few academic centers that are offering it, but it could be perfect for a patient, for example, who has a pacemaker and cannot undergo an MRI examination. This is another test that could help with screening and also in diagnostic settings.
Dr. Parisa Lotfi is an assistant professor of radiology and biomedical imaging, and Dr. Mehra Golshan is a professor of surgical oncology at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.